Good afternoon, everybody. This is Ashley from the Gain Center. I want to thank you for joining us today for the Communities of Practice Psychiatry webinar. Today we'll be hearing from Dr. Marvin Swartz while he discusses what the evidence is for assisted outpatient treatment. If I could just read the quick disclaimer. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. Our quick reminders. Please keep your phones on mute if you're not taking part of the discussion. Please do not put your phones on hold, and we are recording this webinar. Thank you, Dr. Swartz.
Hey, this is Marvin Swartz, and good to meet with you again. We talked a little bit a month ago about how to select candidates for AOT, and the topic for today is to talk about the evidence about AOT and its effectiveness. And I've been involved in what we call in North Carolina involuntary outpatient commitment since the early 90s. I got interested in it because as a psychiatrist working with different populations, I wondered about whether involuntary outpatient commitment, and we'll call it here assisted outpatient treatment, I wondered if that was an effective law and something that we should use. At the time, I was working on an acute inpatient unit and also working in a minimum custody prison in North Carolina, and noticed that a lot of the folks who were frequent flyers in both settings, one, were very similar, and two, often the problem with their care was a lack of treatment compliance, that they had fallen out of treatment, were not taking the prescribed medications, and crashed and burned. So we started at that point getting interested in, well, what is the evidence that these types of laws work, and set out to try to evaluate the evidence and create some of the evidence over the ensuing years. So I'll talk about the studies we've done in North Carolina and New York, and then I'll talk a little bit about the some of the other studies and the what the American Psychiatric Association has recently written about the use of AOT. So just starting out, let me say that these are the criteria for outpatient commitment in North Carolina. North Carolina was one of the first states to have a so-called preventative outpatient commitment law. That is, it was one of the first states in which you could commit someone to AOT from the community. Now, having said that, the vast number of AOT orders in North Carolina and most other places are actually step-downs from inpatient. And there are, in North Carolina, for example, there are very few AOT orders that start de novo in the community. Usually what happens is someone is a committed patient in one of the state institutions or community institutions, and as a form of step down from that AOT order, they're from inpatient commitment, they're given a AOT order. And in fact, in some cases, the AOT order is part of what we call in North Carolina a split commitment, such that the person at their first hearing it gets a period of inpatient and a period of outpatient commitment simultaneously. So the judge might say, well, the first commitment period can be 90 days, so I'll allow 30 days inpatient and 60 days outpatient. Or frequently the judge will say, I'll order a split commitment, and whatever doesn't get used up of the initial 90-day order can be used as a AOT order. So these are the criteria, though, that were established in the early 90s when we recodified our involuntary outpatient commitment law. So the criteria are presence of a serious mental illness, the capacity to survive in the community with available supports, a clinical history indicating a need for treatment to prevent deterioration that would predictably result in dangerousness. So it's not that the person is imminently dangerous, it's that by history, and given the course that the person's on, they could well become dangerous if their non-adherence continues. And then finally, a mental status that limits or negates the individual's ability to make informed decisions to seek or comply voluntarily with recommended treatment. So in the early 90s, in an effort to try to understand whether this law was working well and whether it was effective, we designed the first randomized trial of AOT in the north central region of North Carolina. And so what you see here from the map is that we took what was essentially the catchment area for the state hospital in this region of the state, and we went to the clinics that were sending their patients to either the state hospital for this region or to the regional community hospitals in this region. We said, there's not really convincing evidence one way or another about whether AOT works. And I have air quotes about works because what works means could mean various things. But we said, would you be willing to do an experiment, conduct an experiment in which we evaluated AOT? And part of the premise there is that we recognize that there are some people who are opposed to AOT and some people who were supporters of AOT. And what we said is the best way to get to the bottom of this about whether we should use AOT is to suspend disbelief about its whether it's effective or not and conduct a study. So are you in these counties, and it was Vance, Granville, Franklin, Warren, Orange Person, Chatham, Durham, and eventually Guilford County was added to this. And these were different mental health centers by organization. We said, are you willing to do an experiment? And what we came to in terms of an agreement for a protocol was that anybody who was involuntarily committed to a hospital and was leaving the hospital under an outpatient commitment order, under AOT, would be approached for involvement in the study. And the premise of the study is the person leaving the hospital under outpatient commitment would be offered participation in the study, and under the terms of the study, they would be guaranteed case management, so good access to services in the county that they were returning to, and a 50-50 chance of beating the rap, of being released from the outpatient commitment order, and then they would be immunized against any future outpatient commitment orders for that year. So the idea was that they would be under the order for a year, and they could clearly be rehospitalized, they could be involuntarily inpatient committed, but no one could outpatient commit them if they were in the experimental group. And in the control group, we would observe them without this AOT order. So the study was, does AOT exert any beneficial effect over and above the effect of consistent case management. So that was the idea. And as people were leaving hospitals under having been involuntarily committed and heading for outpatient commitment, they were approached and were randomized to one of the two conditions if they're interested. And what we found was that if you looked straight up at the odds of being readmitted to the hospital month to month over the period of the study, so what were your odds of being rehospitalized next month if you're on outpatient commitment, we found that the group on outpatient commitment was a third less likely to be rehospitalized. So in this month-to-month evaluation. However, what we also found was that whether you were rehospitalized was greatly affected by how long your initial outpatient commitment order was, or your cumulative outpatient commitment order is. And that, what I mean by that is that people have variable lengths of outpatient commitment because of, in order to get more than 90 days, they had to go back to court. The clinicians had to find that they still met criteria for outpatient commitment, and then they had to bring them back to court for a subsequent hearing, and the judge had to order more days of outpatient commitment. So there were some people who the clinician's judge didn't meet criteria anymore, and there were some people that the judge didn't find met criteria for outpatient commitment. And so despite what we had hoped, there was a variable, quote, dose of AOT. So some people got more longer periods of AOT than others. And so you see here that there's a group that had more than 180 days of outpatient commitment, a group that had less than 180 days, and then there are people who, by the condition of the study, got no period of outpatient commitment. And what you see is that the people who had more than 180 days of outpatient commitment were significantly less likely to return to the hospital. And if you look at length of stay, the people who had 180 days or more of outpatient commitment had significantly shorter periods of hospitalization than people who were either in the 180 days, less than 180 days, or in the no outpatient commitment group. So you see a significant benefit in reduced length of stay for people in outpatient commitment. Now recall that this study, as you see here, was published in 1999 when lengths of stay were much longer. And if you did this study again, you probably wouldn't see these as many long lengths of stay as we had in those days. Now, the point being that one, yes, straight up in the experiment, in the RCT, you were significantly less likely to be rehospitalized month to month if you were in the outpatient commitment group. But if you got a longer period of outpatient commitment, you were far more likely to benefit. So we also found that if you had a longer period of outpatient commitment, you were less likely to be violent, so less likely to commit acts of interpersonal violence than if you didn't get a longer period of outpatient commitment. Now, the important thing here is to realize that this is not the type of violence that we're talking about in mass shootings or in school violence or somewhere else. This is the minor, lower levels of violence that people with schizophrenia and severe mental illness get involved in, the pushing, shoving, things like that. There's almost no weapon use. There's almost no serious violence in this. This is just sort of the low level of violence that is the more frequent occurrence with people with severe mental illness. But you see a significant reduction in violence if you got extended periods of outpatient commitment. And you also see a significant reduction in being victimized if you were under outpatient commitment. So this doesn't even depend on a longer period of outpatient commitment. You see here that if you were assigned to this group at all, you had a significant reduction in outpatient violence. Now, we also found some other things that we reported over the years. We saw that people self-rated their quality of life. So people under AOT were much more likely to report an improved quality of life. Their relationships with their families were improved. Their medication adherence improved. They were less likely to be arrested if they had been previously arrested. So there were a whole range of outcomes that improved in this study that we conducted in North Carolina in the 90s. Now, the critique of these studies is that use of the stratifier of 180 days or more of outpatient commitment. So even though we found that anybody assigned to outpatient commitment was less likely to be rehospitalized in this month-to-month perspective, we featured in the paper in the American Journal of Psychiatry the findings of the 180 days or more. And we thought that to report just the straight-up benefit of outpatient commitment in the experimental versus control groups really hid some of the most important finding. And the most important finding to us was two things. One is that people with longer periods of outpatient commitment did better. And two, that people who had intensive services, so got more services as provided by the local mental health center, also did better. So the combination of these two things, a longer period of outpatient commitment and more than 3 visits a month, those work together to reduce rehospitalization and all the good outcomes that we found. But people read that paper. We kind of buried the lead that there was a main effect of outpatient commitment. And by reporting on what we thought was the most clinically responsible way to present the results, that you had to do it for a longer period of time and you had to provide intensive services, that people said, well, you didn't really find a straight-up finding of the benefit of outpatient commitment. You only found the benefit when you looked at long periods of outpatient commitment and intensive services, and really your study was your randomized controlled trial was a failure. And that was really had to do with how we reported the study. And in retrospect, we regret that that's how we reported the study, because we in effect buried the lead that there was a main effect of outpatient commitment. So that was the first randomized controlled trial of outpatient commitment. And if you're an evidence type person, then many evidence people think that the most important evidence about the effectiveness of something is the randomized controlled trial, that's the highest level of evidence. Now, you can dispute that, and many people do, and they say that actually randomized controlled trials aren't always the highest standard of evidence, because to conduct a randomized trial, you have to use very artificial conditions to select people for the trial and to study them, and that real-world evaluation sometimes can be more valuable than RCTs themselves. But at any rate, this was the first RCT. The second RCT was a pilot study at Bellevue Hospital, conducted by Hank Stedman's group at Policy Research Associates. And in that pilot study, so what happened was the New York State Legislature decided, well, there's a lot of talk about involuntary outpatient commitment. Would it be a good thing for New York? And so they put into legislation a pilot study at Bellevue Hospital. So it was a very small scope of a pilot program of AOT only at Bellevue Hospital in New York City. And they found that there was, in a very small study, so that the statistical power to find a benefit was pretty small, but they found, or we found, because we participated in the study as well, that there was no benefit to AOT at Bellevue in this pilot study. And part of the critique of that study was, one, it was small, and two, because it was a pilot study, there was no enforcement of AOT at Bellevue. There were no mechanisms to try to follow up in the case of non-adherence. And so there were no findings of benefits to AOT in that pilot study. Now, despite that, New York did go ahead and pass an AOT bill. And part of the dynamics there, as many of you know, was that New York was, and certainly New York City, was very concerned with quality of life type crimes, that there was a lot of homelessness in New York City. There were incidental street crimes that was felt to be attributable to homelessness and severe mental illness, and the people living on the street and not getting treatment. And that New York City particularly felt that there was a need for an AOT law, which came to a head when there was an incident in the New York subway where Kendra Webdale was pushed under the subway by a person with schizophrenia who was not in treatment, Andrew Goldstein. And so even though the Bellevue study reported back to the legislature that AOT had no benefit, the killing of Kendra Webdale led the legislature, and the Webdale family lending their name to the legislature had a real catalyzing effect in passing AOT in New York. And so in 1999-2000, New York State passed Kendra's Law, which was unusual in that this was the first state that passed a AOT law that had explicit provision to add funds for implementation, and that was in the order of $25 to $30 million, but also a provision to expand services for everyone in the state, to make ACT and intensive case management programs in particular more available to people in the state. So there was also a provision to add permanently $125 million to the state mental health budget to increase the availability of ACT, ICM, intensive case management, and to generally improve services across the state. And so AOT was passed with this sort of carrot and stick of, we're going to pass this law, but we're also going to infuse more funding into New York's mental health system. And so it made it very difficult in terms of the politics of this for advocates to oppose a bill that was going to expand services in New York. So the one proviso that became important in the passage of this bill was that the legislature said, yes, we're going to put this into effect, but there's a lot of concerns about whether AOT is effective, and we're going to require that it sunset every 5 years, and that the legislature review that and decide whether to continue AOT when it gets back a report on how AOT was functioning in New York, and whether it should be continued. So in the first 5 years, the state itself produced an evaluation report. So the Office of Mental Health in New York produced a report that showed, from their perspective, that AOT was of great benefit to recipients across the state. But many of the opponents of AOT said, yeah, well, of course, if you ask the state whether its programs are effective, they're always going to say yes. And so we want an outside evaluation. And so what I'm going to describe briefly here is the outcome of the evaluation that was bid out to external evaluators. And in this case, the external evaluators were people in my shop at Duke, so Duke University, partnering with Policy Research Associates, and the MacArthur Foundation Research Network on mandated community treatment. Those three groups worked together on an evaluation of New York's outpatient treatment program, assisted outpatient treatment program, in the second 5 years of its existence. So just before it needed to be re-upped after the 10th year. And so this study was not a randomized controlled trial because it was not funded at that level, and it really wasn't feasible to conduct it at that time. So what we did was we found that we evaluated a bunch of outcomes using existing data from the AOT program, from Medicaid records, from arrest records, all the existing data files we could aggregate in order to evaluate AOT we used. And so here are some of the findings. The findings are very extensive, and if you want us to send them to you, we can send some of the published reports in peer-reviewed publications or the main report that was delivered to the legislature. So what we found was that if you were under AOT, looking before AOT and after AOT, you are far more likely to receive ACT and ICM. So you see by 180 days, you are 3 times more likely to receive ACT or ICM by the time you reach 6 months. In addition, medication adherence or receipt of the correct medication for the person's condition, and to have that pharmacy record filled. So 88% by 180 days had evidence that they were getting they had a consistent supply of the correct medication for their condition. And this is used as a proxy for medication adherence. If you're doing studies in large populations, one of the ways to measure medication adherence is to see whether they have evidence in their records of consistently filling their key medications, and is the key medication appropriate to their diagnosis. So in this case, a positive medication possession ratio would be that for consistently throughout, say, 6 months, the person had, say, if they had schizophrenia, that they were at least getting an antipsychotic for their condition. And similarly, if they were bipolar, did they have a mood stabilizer or antipsychotic, so on and so forth. So we found that people were far more likely by 6 months to get the right medication for the condition and have it in their possession very consistently. So 90% essentially by 6 months or more were getting the appropriate medication consistently and had those filled. We also found that hospitalization had decreased substantially in this group, and the days hospitalized also decreased. So those are all significant findings. Now, one of the other findings that's important and sometimes gets lost in the debate about the evidence about AOT is that people say, well, if everybody had access to ACT or intensive case management, so that if they got the premier service, then AOT would not be needed. So, for example, if you got everyone who was a revolving door patient on an ACT team or on with intensive case management, well, then you wouldn't need AOT. And so what we did here was went into the data in the New York AOT program and compared people who were receiving ACT with and without AOT. Asking the question is of was there any beneficial effect of AOT combined with ACT? So if the advocates who said, well, you don't need AOT if you have ACT were correct, there would be no additional benefit of AOT over ACT. And what we found here was the monthly probability of hospitalization was reduced about 43 to 57% for participants who received AOT plus ACT or ICM compared to participants who were only receiving ACT or ICM alone. So there's very strong evidence to answer some of the claims of the advocates that, in fact, AOT does exert some benefit over and above ACT or ICM. We also found, and I won't dwell too much on this, but pre-AOT, before someone gets on AOT, their odds of being arrested each month were about 3.7 per month. That was the average. And it went down significantly while people were on AOT. However, when you compare it to some people who were also receiving intensive services, it was not as dramatic. So the answer, the take-home here was, well, if you got on ACT or ICM, yes, your rate of arrest went down from 3.7 to 2.8, but it went down more significantly if you got AOT. So our overall summary of our findings for this were that AOT did improve a range of important outcomes for recipients, and the increased services available under AOT did improve recipient outcomes. But we also found that the AOT court order and its monitoring appears to offer additional benefits in improving outcomes, and that AOT exerts a critical effect on service providers. And so we saw clear evidence in our evaluation that, in fact, the AOT order not only exerted its effect on the client and the family, but also exerted an effect on the providers and made them sort of step up their efforts to engage clients, and that stepping up and that effort to engage in clients was important. So let me just briefly then give you the landscape of the evidence about outpatient commitment, or AOT. There have been 3 systematic reviews of AOT since 2000. There was a study done by RAND that found that there was not that much evidence in support of the benefit of AOT. There was a report by Rachel Churchill in the UK, and there was a Cochrane collaborative report now that's been repeated. It was originally 2011 by Steve Keisley. Now it's been repeated again. And these evidence reviews, all largely done by people who were opposed to AOT, found that there was not that much evidence that AOT is effective. Well, now why is that? Well, largely I would say because the evidence reviews only give weight to randomized controlled trials. So the study I just talked to you about, the New York AOT study, was not counted in any of these reviews, particularly by Keisley, who has the only review after the AOT study in New York. And so they don't count the evidence from these quasi-experimental, quasi-naturalistic studies. They only count the randomized trials because they consider that's the level of evidence needed to support a practice. Now, the three studies that we would reference is one, the Bellevue study that I talked about that found no benefit. Our study at Duke, the Duke Mental Health Study that was originally published in 1999, that we think did show benefit of AOT, and then the New York AOT study that we thought provided substantial evidence of benefit. And we think that the methodology of that was appropriately rigorous enough that we would state with great confidence that the AOT program in New York does provide benefit. But we also think that the way of framing the question about is AOT effective really is not whether it's effective or not. So, you know, when you're thinking about an efficacy or effectiveness of a drug, you say, is drug A better than drug B in a randomized trial format? And so is olanzapine more effective than perfenazine as you know, studied in the Katie study? But we think that if you're thinking about AOT or outpatient commitment, it's a very complicated, complex community intervention that really can't be evaluated as if you're comparing drug A to drug B, and that it's more appropriate to say not is it effective, but can it be effective and for whom? So we think the way to pose the question is not is it effective, but whether it can be effective and under what kinds of conditions and for which populations. And so the variables there that are key are, was it effectively implemented? How was it implemented in the state or the site in question? Was intensive community-based services a part of the order and consistently provided? And was the court order long enough, of active duration, long enough to be effective? And we would say, if under those conditions, yes, OPC or AOT can be effective, but it is not inherently effective, as you would say in a drug trial where, say, olanzapine is more effective than perfenazine or not. So, and that essentially is the position of the American Psychiatric Association that in several years ago issued a position statement, which we can send to you, and also a research document that found essentially this, that outpatient commitment, when effectively implemented, when combined with recovery-oriented intensive community services and provided for an adequate length of time, can be effective. And so that's the position of the American Psychiatric Association about AOT. So I'm going to stop there. And if you have questions or discussion, please write them in, and we'll discuss them. So go ahead if you have any questions or comments. And you see that Ashley solicited any questions that you might have about the evidence. if you also want to write to Ashley or to me requesting any of the papers that I referenced or any of the evidence, we can certainly make that available to you as well.
Okay, this is Ashley. If there's no questions today, I just want to remind everybody about the office hours that we also have available. If anyone would like to schedule office hours, please contact me. I have my information right here. It looks like Elias might have a question.
Yes, do you hear me?
Yep, I can hear you.
Thank you. Dr. Schwartz, I was wondering about those studies that may have been done that applied the conditions that you suggested for evidence of efficacy or evidence that it could indeed work. So while the global reviews, as you pointed out, selectively chose studies that may have maybe added too much noise into the signal, are there studies that deliberately in a prospective manner took into account the conditions you suggested that would be more likely to be associated with success, and that actually did confirm that? Has there been follow-up to pretty much test the hypothesis you were suggesting?
So those are great questions. And actually a very large-scale sort of population-based approach. So the Octet, I didn't have this slide here, but the Octet study was the third randomized trial, and it was conducted in the UK after they passed their mental health. They revised their Mental Health Act, and the Octet study, the principal investigator was Tom Burns. And in that study, that was another RCT, but it found no benefit of what's called in the UK a community treatment order. So that was, by the folks who opposed AOT, that was more evidence that it didn't work. But there's a lot of methodologic issues with that study. But the largest population-based study was conducted, a series of studies were conducted by Steven Segal, S-E-G-A-L, in Australia, because they have very good records in Australia, and they have studied how people have done in Australia under AOT, and they have pretty good evidence using good statistical controls that AOT does benefit people when applied there. So those would be the largest series of naturalistic studies that have followed sort of this kind of design. And we can send you some of those if you'd like.
That would be very helpful. I mean, obviously the concern is that there's tremendous political resistance to many of these things, and there is a lot of polarization even amongst provider communities that sometimes get in the way of even a scientific discourse, let alone actual decisions or implementation. Yeah. And I'm wondering, as we learn in medicine that prostate cancer cannot all be treated with the same approach, breast cancer cannot be effective, breast cancer treatment cannot be effective for all breast cancer patients, I'm wondering if we can maybe identify elements that will help us come up with a process that will get us to a precision medicine in psychiatry as it relates to AOT. Can we truly identify, to your point, in more specific terms, which patients and which characteristics may be associated with greater success with AOT in a way? Is there any work currently underway? Is there any research funding? Is there any initiative to try and address those things?
So that's a great point, because that's really where we're at, is how do you identify good candidates? And the practical way for good candidates for AOT, and the practical question that all of you are facing is, say someone has done well for 6 months under AOT. Is that evidence that you should continue it or you should stop it? Or similarly, if someone hasn't done well for the first 6 months, is that evidence that you should keep trying or not? So how do you figure out who the best candidates are and who's going to benefit, or for whom it's going to be futile? And I think that's a critical question that needs to be answered, but I don't know of any research right now on that. It's very important. I will say one other area of research, which is a little tangential, but I think important, is that we believe that in some of the debate about AOT, the people who are actually affected by it are not being included in the debate. So a lot of the people opposed to AOT are sort of professional advocates and not people, with schizophrenia or families with schizophrenia who are actually involved or affected by the condition. And we did do a study some years ago in North Carolina where we asked people with schizophrenia themselves and their families and clinicians treating them what they thought about outpatient commitment. And to each of those stakeholders said that, really this is a trade-off. It's not in an absolute sense whether AOT is a good or bad thing. And they all said, well, if in fact the benefits of AOT that have been published are being realized, then we would be willing to trade off the loss of civil liberties to gain those things. And so, for example, people with schizophrenia said, if this would keep us out of the hospital, we would accept the court order. That the court order seems like a low price to pay to stay out of the hospital or to stay off the streets or to have safe housing or to not get beat up. And I guess my point is that a lot of the debate about AOT doesn't recognize that it's a relative to what question. And for so many people with schizophrenia and severe mental illness, it really is a relative to what? Relative to living under a bridge? Is a court order, worse than living under a bridge? Is a court order worse than, going to bed scared every night about whether you're going to get beat up? Things like that. And when we empirically did that and said, okay, what do you think, you as a person with schizophrenia, how important is avoiding a court order versus, having the, say, security of AOT, or the benefits of AOT, they tended to endorse that they were willing to go to court to be supervised if they came out ahead.
I mean, I've had
question is really critical.
I've had personal experience with patients. By the way, I don't want to keep on monopolizing here. If there are other questions, I could stop here.
No, it's fine. Go ahead.
I was going to say that I have a handful of patients who have had the experience of maybe a segment of AOT, if you will, that is kind of self-imposed. So they decompensate after having stopped their medications. They end up in real challenging situations, end up in the hospital, get better with treatment, and then on outpatient follow-up, they really almost plead with their providers to give them long-term injectables because they can predict that they're going to come off their medicines again and decompensate and say, I really want to have the injection. I don't want to have this happen again to me.
Right.
But I have to say that's not the majority of patients. So it's kind of a select group of people who are able to recognize that. It's kind of one way, I would say, of AOT is these long-term injectables. It's kind of to some extent.
And we did find in looking at our data and some data other places that pairing a long-acting injectable with an AOT order was very effective. Basically it's using the court order to also sort of reinforce the need for the shot.
Right.
But you're making really important points about this, that and there's a lot of diversity among folks with AOT. I will say another study we did was we wanted to test this idea that years ago this forensic psychiatrist Alan Stone, or he's a famous person who's written a lot about law and psychiatry, he said the best way to evaluate the sort of moral appropriateness of something like AOT is to ask the patients whether in retrospect they would say, thanks, I needed that. And so it's called thank you theory. Thanks, I needed that AOT order. And actually we studied that to see what proportion of patients would, after an AOT, say, thanks, I needed that. And to our great disappointment, I will say very few people, even when they did better, were thankful.
That unfortunately, it confirms my experience as well. While a handful of people who have had bad experiences in the hospital or bad experiences with admissions or AOT-like kinds of interventions recognize that they benefited, they are not sure that they want it again because it's just too intrusive in a way. Right.
Yeah. So waiting for the thank you is not a good idea.
Right. Now the question for me is, how does that compare with? So this is a big question really in psychiatry that unfortunately we haven't had a whole lot of attention to in research or even clinical practice. You don't even find it on the diagnostic criteria in DSM as a primary element, and that is anosognosia, the lack of awareness, if you will.
Right.
And I don't know how it would compare to someone who may have had some kind of a violent intervention to prevent, I don't know, death or cancer or something like this. In my experience, most people would say, well, yes, I didn't have a choice. It caused a lot of complications. I ended up with a lot of toxicity. But yes, that was the right choice anyway. And in retrospect, I probably would still do the same thing. I don't know if the difference between that person and the person suffering from a severe psychiatric illness is inherently related to the illness and their capacity or lack thereof to cognitively manipulate the information to reach deductions that, I guess, are self-serving.
Right. Right.
We're getting off on a tangent here, but I'm enjoying the conversation. Thank you.
No, I think it's the whole notion that there's this construct of lack of insight on a biologic basis is an important part of the discussion. And if you believe, say, the eFoliatory folks, they think about 60% of people with chronic schizophrenia have that condition, a lack of insight based on, brain dysfunction.
Right.
I think, that's a reasonable argument, although there's a lot of other reasons people don't comply. I kind of lump it as can't, that a non-adherence is a group of people who can't, and you could say that's the people who lack insight, don't, and won't, and that the determinants of the can't, won't, or don't might be a little bit different. Sometimes it's they don't have a family that's supporting treatment and helping them get their meds and this and that. Sometimes, they understand, but they just can't get it together.
Well, we are about to start a program here in Baltimore, and I'm trying to learn about this area. It's an area that I have not really learned about before, and trying to kind of figure out how to proceed with it the best way possible.
Yeah, you have an interesting program there. It's the criteria are pretty narrow in Baltimore, right?
Very challenging. We have really been unable to make many referrals from all hospital systems. I think we've been able to yield only one referral in several months. So it's
right.
It's tough.
Now, yeah, explain to people what those, what the problem is there. I think it's interesting.
I'm sorry, you're asking me to explain it?
Yeah.
Yes. So it basically is logistical primarily, I would say, in addition to having somewhat of a high threshold to meet the criteria. So a person has to have been committed to involuntary treatment in a hospital twice in the past year as the first step to even being referred. The logistics of being admitted involuntarily, as many of us know, a patient is admitted involuntarily on certificates, and for practical reasons, the staff and everybody else speaks to them, and they cajole them into signing a voluntary, only for them to be kind of discharged the next day or the day after, or they enter a 72-hour notice, as we have it in Maryland here. So while they functionally were discharged, and the voluntary commitment did not happen because the hearing was not held, the fact that they were admitted involuntarily initially does not count towards this criterion, because they have to have been held by a judge twice a year.
Right,
which
so you can't
frequently doesn't happen.
Voluntary.
Right, so then you try to, so we're kind of learning how to do that, but again, the logistics of it are not trivial. Everybody is struggling to decrease their length of stay and get the patient to the next level of care as quickly as possible. The hearing is not happening for a few more days, and other things that get in the way prevent the capacity to refer patients. And then I heard you say that the program that did not have teeth in it, so to speak, you have no recourse if a person did not adhere to the intervention. Maybe the outcome was not that great. And in this case here, there is somewhat of a limited capacity to intervene if somebody does not adhere.
Right. So you're making great points, and I think they illustrate the principle, and that is that in many places where the advocates were trying to, prevent AOT, they introduced poison pills into the criteria or into the program that made it very difficult to get off the ground. So, for example, California, when Laura's Law was getting enacted, the advocates wanted to do anything they could to keep Laura's Law from going widespread or being very effective. So they introduced this poison pill of, no, it won't be statewide. Each county on its own has to decide whether to do it. And that greatly impeded Laura's Law moving out across California.
Right. It's obviously very charged, very polarizing in our society, and to be truthful, I'm sure a part of this is related to our very sad history in psychiatry. We certainly did engage in abusive practices under the premise of wanting to take care of people, when we sterilized people without their consent, and when we did a lot of things. So on the other hand, one can understand some of the reasons and some of the dynamics that lead to this approach or to these occurrences.
Gotcha. Well, thanks for your comments.
Thank you. Thank you very much. Very, very helpful indeed, and very informative. I appreciate it.
Any other quick questions before we go? Well, you see the slide here, and if you want to talk one-on-one about AOT, we're happy to do so. It doesn't have to be about this. It can be anything related to the program. Or if you need other resources, just let Ashley know, or let me know. We'll be happy to support you.
Wonderful. Thank you again.
Okay.
Thanks so much, Dr. Swartz.
Okay. Take care, everybody.